Divine Protection Prayer for our health workers. Heavenly Father, grant us your mercy and grace. Bless the works of our medical experts who have dedicated their lives attending to the afflicted and suffering. Keep them safe, together with their families and loved ones. Bless all our medical experts at the forefront of this critical mission, that through their presence and care, the world may see hope and experience your divine love and healing. We ask this in your mighty name. Amen.
Hello and good afternoon, everyone. I am Joanna C. and I will be your host for this afternoon. Welcome to PICU M.R.T. Season 2 third station with the theme Pediatric Traumatic Brain Injury. And today is April 20, 2022. Before we start, let me just guide you on a few reminders.
Delex House Rules. As working professionals, let us show respect while the webinar is ongoing. Avoid using the chat and Q&A boxes for concerns and comments not related to the lectures, such as e-certificates, etc. And please refrain from using foul words. You may send us a private message on our Facebook pages for concerns at Delex-ICU Forum or at Delex Pharma. Let's show decency at all times, whenever and wherever we are. The certificate will be sent to the attendee's email within 15 working days. Only those who registered and attended via Zoom will be issued with an e-certificate. Don't leave the webinar session without answering the evaluation form. A QR code will be flashed at the end of the webinar. The evaluation link will also be posted in the Zoom chat box. Failure to answer the evaluation form means no e-certificate. Attendees' requests for the evaluation form, post-tests on our FB pages, and email will not be entertained. So, please do not leave the session without answering the evaluation form. An attendee will only avail of an e-certificate if he/she stays at the webinar session not less than 60 minutes. Registration is not allowed while webinar is ongoing. You can still learn with us via our FB Live. When joining the webinar, please secure a stable internet connection to avoid being logged out from the webinar. Concerns regarding internet connectivity will not be entertained. When to follow up the e-certificate. An attendee may follow up an e-certificate if he or she did not receive it on the given period of distribution. The certificate will be sent to the attendee's email in 15 working days. An attendee may follow up when he or she has answered the evaluation form, post-test, pre-test. If a participant did not comply with the guideline, the concern will not be entertained. Reasons why an attendee may not receive the e-certificate. The provided email in the evaluation form is invalid. Make sure that your email is active, free from typographical error, free from unnecessary characters. If an email is invalid, our message to the recipient bounces back. We also advise that an attendee will make sure that his or her inbox is not full. This may result in bounced emails. Thus, an attendee will not receive any email from us. The attendee did not answer the evaluation, post-test, pre-test provided during the webinar. Please answer it before leaving the session.
To formally welcome us all, I would like to introduce the Program Director of the PICU Forum. She is a graduate of Fatima University College of Medicine, finished her residency in pediatrics and fellowship in pediatric clinical care at Philippine Children's Medical Center. She had her clinical fellowship rotation in pediatric critical care at Johns Hopkins Children's Center in Baltimore, Maryland, USA, a master's degree holder in hospital services administration from Ateneo Graduate School of Business. She is a fellow of the Philippine Pediatric Society, Society of Pediatric Critical Care Medicine of the Philippines, and Philippine Society of Critical Care Medicine, the Medical Specialist 3 and Training Officer, Pediatric Critical Care Center of PCMC, a Philippine representative, Asian chapter of World Federation of Pediatric Intensive and Critical Care Society, and a past president of SPCCMP. Let us all welcome Dr. Rodelia G. Cipriano.
Hello everyone and welcome to the third station, Season 2 of PICU M.R.T. Unintentional injuries are the leading cause of death in children. And of all the types of traumatic injuries, brain injuries are more likely to cause death or permanent disability. For today, we are very fortunate to have with us Dr. Arun Bansal from Chandigarh, India, to share with us his expertise on the topic traumatic brain injury in pediatrics. So, let's all get ready and enjoy this learning journey. Happy listening and good afternoon.
Thank you, Dr. Cipriano. Once again, good afternoon to our participants all over the world. Just keep coming in, guys. You're just right in time. For those who just logged in, welcome to our PICU M.R.T. Season 2 third station on pediatric traumatic brain injury. I know you are all excited, so I won't keep you waiting. Let me now introduce you to our lovely moderator. She is a graduate of University of Santo Tomas Faculty of Medicine and Surgery. She had her residency in pediatrics at Philippine Children's Medical Center and fellowship in Pediatric Critical Care Medicine PCMC. She is a diplomate at Philippine Pediatric Society and Society of Pediatric Critical Care Medicine of the Philippines, a fellow of Society of Critical Care Medicine. Ladies and gentlemen, let us all welcome our moderator, Dr. Mary Joy S. Torres.
Traumatic brain injury is a leading reason of fatality and disability in children. Studies imply that children demonstrate specific pathological response to TBI with diverse associated neurological symptoms. Hence, diagnosis, treatment, prevention of complications, and long-term outcomes vary significantly. Addressing traumatic brain injury in the pediatric population is remarkably intricate because of numerous significant developmental milestones. To tackle these imperative issues, PICU M.R.T. invited a very distinct speaker from India, which is no other than Dr. Arun Bansal. Dr. Arun Bansal is a professor of Postgraduate Institute of Medical Education and Research, Chandigarh, India. This hospital is one of the largest tertiary referral hospitals in this country. He also finished his medical degree in the same institution. He completed his residency training at Royal College of Pediatrics and Child Health and had his Pediatric Critical Care Fellowship at St. Mary's Hospital, London. Dr. Bansal showed passionate importance in clinical work, academics, and research. He was part of the team that started pediatric critical care in India. He published more than hundreds of papers, a well-known editor of pediatric critical care books, and currently busy as primary investigator of ongoing research projects. His research papers acclaim several awards both in India and internationally. Indeed, his contributions in the field of pediatric critical care is very well admired and legendary. Colleagues, without further ado, let us all listen to our very esteemed speaker, Dr. Arun Bansal.
Good day, everybody. Thank you so much. At the outset, I would like to thank the organizers of the Philippines Pediatric Critical Care Society for giving me an opportunity again to speak on this topic on pediatric TBI. It's really an honor to be invited by your society, and I bring my greetings from India, and I work at Chandigarh. This is my city. It's a beautiful city. I would like to welcome you all. Please do visit whenever you get a chance. This is my institute where I work, and this is my center, Advanced Pediatric Center, where I've been fortunate enough to work since last few years. Before I start my lecture, I would like to share that I have no conflict of interest and I have no disclosures to add. This is the brief outline in which I would like to focus my talk for the next 30 to 40 minutes. So starting with the epidemiology, why it is important? Because pediatric TBI is a very common cause of morbidity. It's one of the common causes of mortality, and it's a very frequent reasons for emergency department visits. It affects more than 3 million children every year. In US, it leads to significant hospital admissions, more than 600,000 ED visits, and more than 6,200 deaths per year are associated with traumatic brain injuries. It has got a bimodal age pattern. One is the young infants or the young children, and then are the young adolescents. But the causes are different. Young infants are more due to falls from the bed, the chair, or while playing. But adolescents have injury because more of falls, fights, or motor vehicle accidents. Male predominance is more in children who are more than 3-year-old, and traumatic injuries to the brain are more common in young children than in the adolescents. Various injuries can occur. It can have a non-penetrating cranial trauma, or the injury can penetrate the brain and cause significant damage. It can have axonal shearing due to the whiplash, and you can have the concussion injury or the contra-coup, and the contra-coup injuries can also occur. Before we go to the management of TBI, understanding the pathophysiology is very important, because before that will also guide us in how we manage these children in our emergency or ICU. In pathophysiology or TBI, understanding the role of cerebral blood flow and autoregulation is very important. So cerebral blood flow is basically the velocity of blood through the cerebral circulation. In adults, it is approximately 50 to 55 ml per 100 gram of brain tissue per minute. In young children, the blood flow is quite high, which settles down to adult levels by the teenage. Following any trauma to the brain, the cerebral blood flow circulation decreases by 50%, and it starts immediately and can occur from 6 to 12 hours after the injury. Then gradually the blood flow starts improving. But if a child is comatose or persists to be comatose for a longer period, then the blood flow can remain below normal for days or weeks together. And this can be one of the main reasons for prolonged morbidities and mortalities. Can we measure the blood flow? There are various ways. You can use transcranial Doppler. You can use these specific CT images. But cerebral blood perfusion pressure is a surrogate marker for cerebral perfusion. If you have the facility to monitor cerebral perfusion pressure, it is an indirect way of measuring that. And also intact cerebral autoregulation is present. It tells you about the good correlation between the cerebral perfusion pressure and the cerebral blood flow. What is autoregulation? I'll come in the next couple of slides. Before that, we need to know what is the Monro-Calorie doctrine. I think in our MBBS or undergraduate days, or especially in postgraduate training, we had read about this, that brain is a closed structure. It comprises of 3 things: the brain tissue, which is the major part, then equally of 10% of the CSF and the blood. When any imbalance occur in any of these 3 components, it displaces or compresses the other 2. The body tries to compensate initially if the increase in the volume occurs in any of the one or any more of these intracerebral compartments. But after a certain increase in the volume, it tends to give way, and then the ICP shoots like anything, and then even a small change in the volume can lead to a significant change in the ICP. So these compensation mechanism which are happening inside the body is the autoregulation mechanism. So we will understand this better in this graph. In the x-axis, we have the pressures that can be either the mean arterial pressure or the CPP, and in this is the cerebral blood flow on the y-axis. So if from 50 to 150 millimeter of pressure of mean arterial pressure, the body can try to compensate the cerebral blood flow. It does not increase or decrease significantly between this wide range of the blood pressure. But if it increases, the map increases further, then the blood flow can increase significantly, or if it falls below 50, then it can also decrease significantly in that. So maintaining the cerebral blood flow in this range, between this range of mean arterial pressure is what is autoregulation. So this can get impaired, autoregulation can get impaired after the injury to the brain. So this can further make the brain prone to secondary insults and also lead to significant damage. So any increase in the cerebral blood flow or decrease in the cerebral blood flow, both are detrimental to the outcome. We don't want that. When an injury occurs to the brain, it leads to the impact of the injury is the primary cause of the brain injury. It is basically the direct impact of the brain of the injury on the brain. Can lead to the cortical disruption and axonal injury can occur. The events occurring subsequently to the primary insult are called as the secondary brain injury, and our role comes in here to prevent or decrease this insult to the minimum. Other problem which can occur with the brain injuries are the skull fractures. It can be linear or stellate, and skull base fractures, if they occur, they need a greater force than simple cranial wall fractures. And base skull fractures usually have these classical signs like the battle sign, raccoon eyes. It can also be associated with CNF rhinaria or otori. Secondary brain injury is to prevent these injuries is the main aim of the management of TBI. And these secondary insults which occur can both be macroscopic and microscopic, and both combined together lead to a significant sequelae or damage. The major role of the secondary insult is played by hypoxia and hypotension, though many other factors are also playing a role. Any injury to the brain can lead to cerebral edema. So it can either be vasogenic or cytotoxic. Vasogenic basically is because there is a disruption of the blood-brain barrier. The fluid inside the cells or inside the vessel leaks outside into the interstitial space of the brain parenchyma, and it leads to imbalance or pressure, increase in the pressure inside the brain. The volume inside the brain gets increased and leads to the raised ICP and compromise in the cerebral blood. But if the cells inside of the brain get edematous because of the injury, it leads to the cytotoxic edema. This edema can occur immediately after injury, and it worsens or peaks by 72 to 96 hours and then start improving over the next few days or weeks. So now we come to the management of TBI. But before we come to the management of TBI in the ICUs or in a referral center, I would like to speak that what are the role of at the management at the peripheral health hospital or at the initial management of these injuries. So I'd like to spend a couple of minutes on this, that what can we do at the peripheral level. So the principle of management is the same, whether at the periphery or whether at the referral center or in the ICUs. The basis is that what we have discussed, the Monroe-Calery doctrine and avoiding the secondary insults. And how do we achieve that? By optimizing the cerebral blood flow. We will discuss that how we can do. Decreasing the cerebral ischemia. All our interventions are directed to decrease the ICP, avoid hyperemia, and ensuring adequate oxygenation and blood flow. So we'll discuss each one of these step by step. But for this, we need to start with initial evaluation of your ABCs, provide good oxygenation and ventilation, address any ongoing blood losses. We need to stop those bleeders, avoid hypotension and hypoxemia. Hypotension is more dangerous. We need to be very careful, and it's in fact more dangerous than hypoxia. Also, if we have to, don't be in a hurry to intubate and ventilate these kids, because it has been shown that even effective bag and mask ventilation in the field or at the periphery is equally good in salvaging or managing, and as compared to the endotracheal intubation. Other things which you have to do is, like I said, control the bleeding. And how you can control the hypovolemia? By giving the isotonic crystalloid fluid. So start maintenance fluid, or in case needed, give a bolus of crystalloid fluid, but don't give colloids at the peripheral or in the field. Hyperglycemia and hypoglycemia both are bad, but avoid dextrose containing fluids in this group of patients. Don't use hyperventilation or any hyperosmotic agents in the field. Use only if there is signs of impending herniation. Otherwise, don't use them. Refer your child to a trauma center where all these things will be done. After stabilizing these steps, stabilizing the spine, and following these basic few steps. When the child arrives in the emergency, there you can intubate after your proper examination and doing a ATLS protocol of intubation and stabilization, start fluid resuscitation. Do a very detailed and thorough neurological examination and monitor the GCS closely, and keep a good record of that in your monitoring chart. Any traumatic brain injury can be mild, moderate, and severe. Mild is when your GCS is between 14 to 15. Fortunately, majority of the patients are of this category, mild, and they recover. Almost all of them recover fully. You can do a non-contrast CT in these cases. But if the child is asymptomatic and neurologically normal, don't do a CT in that cases. If the child is asymptomatic, you can observe for a few hours or overnight and then discharge. But if the child is having penetrating injury to the brain, skull fracture is there, child is unconscious, or the sensorium is worsening, is complaining of severe headache, or is intoxicated, especially adolescents, and all the CT is not available, or there is a leak of CSF or other organ injuries are there, then admit the child, don't send him, and do a complete workup and monitoring in that cases. Any child with GCS of 9 to 13 has labeled as moderate TBI, and almost 10% of the patients in the emergency present in the moderate phase. The initial management, whether it is mild, moderate, or severe, is the same in all these groups. But in this case, you don't send them home. You have to do CT head in that cases, along with few blood studies like hemoglobin, coagulogram, clotting factors. You also have to do blood for cross-match, blood sugar. All these are important. But the good part is that they also have very good outcome if handled properly and managed as per protocol. What is the role of CT head? Whether we have to do it or overdo it or not do it, I would like to discuss a couple of slides on that how can we help it, because CTs are important and they can help to diagnose the intracerebral injuries, infarcts, hematomas, or anything which are there. There have been various societies or organizations have developed certain clinical decision rules. We will discuss which one are the good ones and which one we can follow, because they help to prioritize your case, whether how to manage them, and will also help to avoid large number of unnecessary CT scans which we have been doing. This was a study in Annals on Emergency Medicine in which they compared these three commonly used decision rules, that the pecan tool, cash tool, and the chalice rule, in children with minor TBIs. And in this, they had included more than 1,000 children. 21 children had significantly important or TBI injury. And they found that the physician examination or decision and the pecan rule had very good results in predicting the need for CT scan, in fact, up to 100%. Physician alone decision based on his clinical examination and his skills or experience, 95% of time he was right. The other two had poor correlation with the need for CT scan. So they concluded that combination of physician experience and the PICU tool identify all the clinically important traumatic brain injuries. This is a systematic review in archives, in which they had included almost 80,000 children with minor TBI. And they also found that the PICU rule, that's a Pediatric Emergency Care Applied Research Network rule, is most consistent and has got highly sensitive and also good specificity in these cases to decide the need for CT head. Now, coming to the most important part of the children with severe TBI who had a who can have a very florid course and test us to the extreme. So these are the children who have a GCS varying between 3 to 8 are classified as severe TBI. We have been given these guidelines by the Pediatric Brain and Trauma Foundation, and that how to manage the cases of severe TBI in the ICUs. Unfortunately, most of these guidelines have very weak recommendations because we don't have any good quality evidence available at present with us, and especially hardly any RCTs are available on various steps in the management of TBI, severe TBI cases. But what has been known is that if we follow these guidelines, it has been associated with improved outcome and decreased mortality. So following these guidelines is important. These were published in 2019 in PCCM. Surgical surgery is an important part in the management of severe TBI because they can have intracranial bleed, hematomas, which can lead to significant mass effect. And if you don't drain it, it can lead to significant sequelae. So get an initial CT scan after your resuscitation and stabilization. If there is a midline shift, which is more than 5 mm, it is significant. And you can repeat the CT after imaging, or if there is any secondary worsenings are there, so then repeat CT head is required. Good oxygenation is very important. Hypoxia is bad because it can lead to tissue hypoxia, which can lead to reflexive hyperemia. And this is known to cause or worsen ICP in the brain. So you need to target oxygenation between 90 to 100, PCO2 between 35 to 40. We don't want hypocarbia. And your PEEP or the ventilatory pressures should be targeted to maintain a FiO2 of less than 0.5. So this is ventilation becomes an important part. Cardiovascular support, like I said, hypotension or shock is the most part which is more dangerous in the hypoxia. So shock is multifactorial in any child with TBI. It can be due to the blood loss. It can be distributive because of the spinal injury, or it can be tension pneumothorax can lead to obstructive shock in that cases. So we need to target each and every cause of the step for the shock in these cases. But if it is mainly because of the hemorrhage or the blood losses, then treat aggressively with fluids and or vasoactive agents. It's important because hypotension or low blood pressure is independently associated with poor outcome. Give fluids to target normovolemia. Start maintenance fluid and don't overdo it. Keep it at approximately 70 to 80% of the maintenance fluid. Keep a zero or a neutral fluid balance and target a urine output of more than 1 ml per kg per hour. But we don't want polyuria, so this much is good enough. Position your child, raise the head end up to 15 to 30 degree and maintain it midline. It will prevent your drainage of the blood to the brain, and also it will not obstruct the blood coming down. So this position is very important, and it will also control your ICP. Sedation and analgesia is an important part, but sometimes are often overlooked because any painful stimuli, and these children with TBI, especially with other organ injuries or fractures, can have significant pain. It can increase your basal metabolic rate significantly. And any noxious stimuli can also increase your intracranial pressure. Moreover, this painful stimuli can increase the sympathetic tone, which can increase your blood pressure, and then patient can start bleeding from the operative side. So we don't want this blood loss and hypovolemia occurring, especially in the hidden cavities. Also, pseudoanaesthesia decreases the ICP. It decreases the cerebral metabolic rate and thereby decreases the cerebral blood flow. And the guideline of the Brain Trauma Foundation recommend the benzodiazepine opioid combination as a good pseudoanalgesic combination. Early nutrition is very important and has been one of the independently associated factor with improved clinical outcome in the pediatric TBI. Hyperglycemia is very common post-trauma, and severity of hyperglycemia is also associated with worse outcome, increased mortality, and longer duration of PICU and hospital stay. Hypoglycemia is also equally bad. So we have to avoid both hyper and hypoglycemia. Nutrition, this is one of the RCTs which was published in PCCM in 2018, in which they had divided children into 4 groups. Group 1 was who had started nutrition beyond 7 days. Group 2 was if nutrition was started within 48 hours. Group 3, if nutrition was started 48 to 72 hours. And group 4 was child was started on nutrition between 72 hours to 7 days. And it was seen that the better outcome was seen in children who were started in early nutrition. Similarly, Glasgow outcome scale was better in children who had started with early nutrition. Now, coming to the important part of the intracranial hypertension, which is very common in the traumatic brain injury, and also intracranial hypertension is the leading cause of death in TBI cases. So ICP monitoring has shown significant improvement in mortality, especially in severe TBI cases or in GCS of 3 to 5. Various catheters are available. We can use intraparenchymal or intraventricular catheters. The threshold, usually we target ICP less than 20 and CPP somewhere between 45 to 65 millimeters of mercury. Which pathway? There are 2 pathways in the management of ICP, whether you target the ICP or you target the CPP. Both are important. So what are the advantages of following the CPP pathway? In that, basically, you are trying to target the cerebral perfusion pressure above 40-45 in infants and in adolescents above 50 to 55. Basically, what is cerebral perfusion pressure? It is the difference of the MAP and the ICP. So you intervene to increase your MAP, which is you might need to give some fluids, or you can start inotrope to target your MAP of 50th centile, which will indirectly increase your cerebral perfusion pressure more than 50. So basically, in that, you also allow permissive intracranial hypertension. Provided your CPP is adequate, you don't intervene to lower the intracranial hypertension or intracranial pressures. So we don't aim to intervene to achieve the ICP below 20. So even if the ICP is above 20, but if your CPP is above in your target range between 40 to 65, you're okay with that. We did to see that which pathway is better, the ICP or the CPP targeted therapy is better. We did the RCT on that, which was published in Critical Care Medicine. So we saw that the survival was better in the CPP targeted group as compared to the ICP group, and it was quite significant. Similarly, we saw that the GCS improvement was better in the cerebral perfusion pressure arm than in the ICP group. The hospital stay was shorter in the CPP group than in the ICP group. So we concluded that targeting CPP pathway is better than targeting the ICP pathway. Can we have a non-invasive way of measuring the cerebral perfusion pressure? People have tried using the ultrasonography to measure you have used transcranial Doppler. They've used optic nerve sheath diameter, see the raised ICP, and then indirectly correlating with CPP. This is one of the studies published in Child Nervous System. There you've seen 23 children, done some paired assessment. They also measured the invasive cerebral perfusion pressure. with the TCD, they estimated the CPP. They found that there was no agreement between the both. And they said that they concluded that to use TCD to measure the CPP as not, it's the evidence is not sufficient. And this is the scatter plot which you have seen, it's widely scattered, and there was no agreement or correlation between the estimated CPP and the absolute invasively measured cerebral perfusion pressure. We also at our center try to look at the role of the TCD and the optic nerve sheath diameter in the measurement of ICP. We had divided our children into 3 groups. One was with the neurologically injured and with raised ICP. In that, we found that the ONSD was quite high, which was up to 5.71. Then we have the neurologically controlled, means they had a CNS insult, but ICP was under control. The ONSD was again high in that, but less than the group 1. Then we had a healthy control, in that means in which there was no CNS insult. So they act as the observation group, in which they had a baseline ONSD of 3.71. So we concluded that a cutoff of 4 millimeter of ONSD can predict ICP with good sensitivity and specificity. We also use the pulsatility index and the resistive index. So the pulsatility index was 0.571 and the resistive index was 0.571 on the transcranial Doppler in the measurement of CPP. So ONSD can be a good tool to measure ICP in these cases. Coming to the specific therapy, hyperosmolar therapy, the mannitol and the hypertonic saline. Mannitol basically works by the 2 primary mechanisms. One is the rheologic effects. Basically, it decreases the blood viscosity and also decreases the blood vessel diameter. The other mechanism is it's a very potent or a very strong osmotic diuretic. But due to that, it has got its own side effects because it can decrease your intravascular volume and thereby decreases the cerebral perfusion pressure. Also, mannitol is associated with acute tubular necrosis. So we need to target the osmolality less than 320. Otherwise, you can have the acute kidney injury in this caused by iatrogenic mannitol. Other drug which is now catching up is the hypertonic saline, or has now been commonly used. Various concentrations have been used by various clinicians or authors. How does it act? It pulls the fluid from the interstitium. That's the vasogenic edema, the fluid which has leaked into the interstitium, and it pulls into the intravascular space. And it also does not have a diuretic effect. So you can use a bolus initially, and then start an infusion of 0.1 to 1.5 ml per kg per hour. It has got good beneficial properties. It's vasostabilizer, it's good hemodynamic stability, neurochemical, and good immunological properties. And you can tolerate osmolality up to 360 milliosmoles in this. So this is the comparative table between the mannitol and hypertonic saline, the doses, the mechanism of action, the side effects, and the beneficial effects. So I'll not go into that. We again did one of the RCT comparing the 20% mannitol with 3% hypertonic saline in children with raised ICP. And we saw that the ICP was better controlled in the hypertonic saline arm. The lower one is the lower line graph is the hypertonic saline. The upper one in this graph is the mannitol arm. So you can very well appreciate that the fall was early and better and sustained in the hypertonic saline arm. And similarly, the CPP was better in the hypertonic saline arm. In this, the upper line graph is the hypertonic saline group. Then the delta ICP and the delta CPP, that is the change of the ICP and CPP from the baseline, were also better in the hypertonic saline arm. So we concluded that the ICP was better controlled, the CPP was better achieved in the hypertonic saline arm group. Any role of anticonvulsants or a prophylactic anticonvulsants? Because up to 30% of the kids can have seizures, which can be even subclinical or non-convulsive seizures. And they occur mainly in younger patients. If they occur, are associated with worse outcome. So starting early anticonvulsants can prevent the early post-traumatic seizure. What do we mean by early? That is in less than 7 days. But if the seizure, they do not prevent the late post-traumatic seizure, that is seizures occurring beyond 7 days. So always put your kids on continuous EEG to monitor the non-convulsive status and to catch them early and start anticonvulsants in that stage, kids. This is one of the studies from USA in which they had a 5-year database, national database, in which they included kids with traumatic brain injury. Large number of patients of TBI were included, and out of that, approximately 10,000 kids developed post-traumatic seizures in that case. And in that, they found that the younger age, that is children less than 5 years, were more prone to having seizures in that as compared to children more than 6, 11, or 16-year-old. Also, any episode of loss of consciousness, whether it was brief or prolonged, are significantly associated with occurrence of post-traumatic seizure. Another factor which was associated with post-traumatic seizure was any amount of bleed, whether it is subarachnoid, subdural, or extradural, or lacerations, also were significantly associated with post-traumatic seizure. So this group of patients are more prone to develop post-traumatic seizures and may have a role in starting anticonvulsants in that. So once we have done this management of severe TBI, the initial management, we may always not be successful. Sometimes these kids can land up into what we call as refractory intracranial hypertension. So again, a big headache for us. How do we manage that? Not many things are available or evidences are available in favor or against these therapies which are there with us. We can use decompression, we can use barbiturate, hyperventilation, lumbar drain, or moderate hypothermia. Unfortunately, up to 40% of the severe TBI cases can develop refractory hypertension, and we may end up using one or the other modalities in our ICUs. Decompression basically is important because in children we can have diffuse brain swelling than the adults. But what does the evidence say? It says that decompression in children does not affect the mortality, but it can improve the long-term outcome in the survivors. Again, it's still a good factor. And it's also effective if performed early, but we don't have a definition for early. We don't know whether it is early 6 hours, 12 hours, 24 hours, or when, but as early as possible is what I would say. This is one of the systematic review of 260 patients in which there were 12 studies were included, which almost all of them were case series, only one RCT was there. 9 studies concluded that the decompression reduced the ICP significantly, and it was persistent. Only 2 studies have shown mortality benefits. Both these studies by Cho et al. And Josen et al. Had shown better outcome in mortality. 10 out of 12 studies have shown positive long-term outcome in these cases. So decompression has its own role, but the timing or the indications are still to be resolved, and we need to have more data on that. We again in our institute looked into the role of decompression in children with raised ICP of non-traumatic injuries, published in British Journal of Neurosurgery. We had successfully discharged 30 children, and 16 had good outcome at discharge, and 14 had good outcome at discharge at 6-month follow-up. So again, it has been seen that decompression these children can have very good outcome if done early and properly. What does this barbiturate therapy has a role? Because it suppresses your brain metabolism and it has a membrane stabilizing effect. Studies have shown that it can decrease ICP in 30% of the children with refractory ICH. But again, like decompression, it has no effect on mortality. Moreover, it has got significant side effects of hypertension, myocardial depression, requiring fluids and inotropes. So we have to be very careful and watchful and do a good monitoring. Multimodal hemodynamic monitoring is required. Hyperventilation is limited only for acute herniation syndrome and refractory ICH, and should be restricted only for a brief period of time. Hypothermia, does it have any role? Because theoretically, fever is bad. It can decrease your metabolic rate. It can lower the seizure threshold, and seizures we know can worsen the raised ICP. Fever in itself is associated with worse outcome, as each Celsius in drop in the body temperature decreases the cerebral metabolic rate by 6 to 8% and also decreases the ICP. So these are the basis on which hypothermia was projected, and many studies were done initially in the early 2000 or from 2010 to 20. The largest one was the school kids RCT published in Lancet. They showed that hypothermia has no benefit in managing this outcome of these children with TBI. In fact, these studies have shown harm in management this or mortality harm in these cases. Moreover, rapid rewarming is also associated with worse outcome. So hypothermia is restricted to a very select group of patients, and only mild hypothermia is to be done, and that also for a shorter period of time. Now, ultimate aim of any of clinician is the outcome. So after all this, what we have done, does outcome make any difference, or do we have a good outcome in these cases? Fortunately, yes, because most children by themselves do well, or by our protocolized treatment do well, and they return to normal, because majority are in mild to moderate TBIs. Mortality in pediatric TBI is very low. But what are the factors which can tell you that these children are going to perform bad, especially unequal pupillary responses or dilated pupils, hypothermia at admission, and the mechanism of injury are associated with poor outcome both and survival. Severe TBI cases, even if discharged, majority of them die within 1 year. So they also have a bad outcome even after discharge. If survival, they can have significant cognitive deficit, and they are dependent lifelong on their parents or caregivers, and they lead to significant financial burden on the family. So that's why it is important. Why pediatric TBI cases are important? Because they have a long life ahead, and they can be a burden both economically and financially and emotionally on the family. So we have to be aggressive and follow the protocolized management. Does the outcome differ between the high income countries and the middle income countries? This is one of the very good paper published in Frontiers in 2021. This is the Phoenix Children Hospital, and this is a Colombian National University Hospital in Colombia, which has a very bare minimum resources to manage TB. And they found that death and children with disability, severe, moderate, or low, were similar. So it's not the high-end gadgets or interventions, but it is the protocolized and proper treatment or support, basic initial support, which is more important, can lead to good outcome. So in the end, I would like to summarize by saying that traumatic brain injury in children is present with broad spectrum of presentation. Fortunately, prognosis is good, and they can have very good, excellent recovery. But children with severe TBI can have severe morbidity and mortality. But systematic approach, fortunately, can lead to good clinical outcome. And following this protocolized guideline also has resulted in better survival and outcome. These are the flow charts of the algorithm published in PCCM 2019 by the Brain Trauma Foundation. So you can all go through it. It has given you the CPP pathway, the ICP pathway, what to do, when to do the surgery, when to do the CT scan, and what all steps to follow, and what all can be done in refractory raised ICP, or when to do a repeat CT scan. So all are there. So I would like to thank again, and I am really honored to be here with all of you and for your patient listening. And I can take up all your questions now. So thank you so much.
While motorcycles are gaining popularity in the country, Statistics shows that there is an increasing trend on road accidents for the past years, with an average of 178 road crash every single day. Head injury following road traffic collision is more common in low-middle income countries. Traumatic brain injury due to road accidents is just one of the leading causes of increased intracranial pressure. Serious complications of increased intracranial pressure includes seizures, stroke, and neurological damage that may lead to death if not given the proper management within the golden hour period. The hour immediately following traumatic injury, in which medical treatment to prevent irreversible internal damage and optimize the chance of survival is the most effective. Managing TBI with a traditional osmotic agent crosses the blood-brain barrier that may draw fluid into the central nervous system, thus can aggravate vasogenic edema. When rebound effect is the problem, hypertonic lactate resuscitates and energizes with Totilac. Totilac contains lactate that serves as an energy substrate and does not cause lactic acidosis. Totilac has a more prolonged and more pronounced decrease of intracranial pressure and sustained improvement in cerebral perfusion pressure. Moreover, it improves neurocognitive functions. When rebound effect is the problem, Totilac, the hypertonic lactate that resuscitates and energizes. Totilac, now PNF approved. Be one with us in our advocacy to support the house parents in Elsie Gatch's village, who oversee the welfare of abandoned and neglected children with special needs. Your prescription of Totilac don't just save lives, but transform the lives of these children.
It's now time for our Slido quiz. To join, use your mobile phone to answer. Go to phone browser and type slido.com or scan the QR code flash on the screen in order to go to slido.com. Enter the PIN code flash on screen and input your complete name as username. 3 questions will be asked based on the topic delivered. The top 3 participants with the highest accumulated scores will be declared as winners of the round. Winners with incomplete names will be disqualified, and the next participant with the highest score and complete name will be awarded as a winner. The winners will get 2 boxes of Easy Vit multivitamins worth 810 pesos. So, are you ready? Okay, so moving on to the best part of this webinar, the Slido quiz. Let us see how our dear participants have learned from the lecture entitled Pediatric Traumatic Brain Injury 101 by Dr. Arun Bansal. In order to join, please scan the QR code and win 2 boxes of Easy Vit multivitamins. You only have 15 seconds to answer the questions. Better make sure to answer them quickly and accurately so that you will get more chances of winning. So here's the first question. 15 minutes to answer. Or 15 seconds. Sorry. And the answer is letter C. 33% of our participants got the correct answer. And for the next question, ten seconds. And the correct answer is letter C. 25% of our participants got the correct answer. And for the last question, five seconds. And the correct answer is letter A. Most of our participants got the correct answer. Congratulations to the winners! Johanna Lines Silva, Franz Joseph Biboso, and Jehan Rosel Santos. Congratulations to our dear winners, and thank you to all of those who participated. Before we move on to the Q&A session, let us watch some AVPs.
Sepsis, a life-threatening organ dysfunction caused by a dysregulated host response to infection. Sepsis and septic shock are major healthcare problems, impacting millions of people around the world each year and killing between 1 in 3 and 1 in 6 of those it affects. Shock is common in critically ill patients with COVID-19, developing in up to 67% of patients in intensive care, and is associated with high mortality. In the recent guidelines issued on care of critically ill adult patients with COVID-19, norepinephrine is recommended as the first-line vasopressor for adults with COVID-19 and shock. But sepsis and COVID-19 do not only affect the health of the patient. Sepsis and COVID-19 can cause financial burden and has an impact in the environment as well. Although there are positive effects brought about by the lockdown, there is a growing concern in the increasing medical waste generated from hospitals and public's use of disposable safety equipment. Brought about by sepsis and COVID-19, there is a need for an ideal norepinephrine solution to manage hypotension due to shock to achieve mean arterial pressure greater than 65 mm per mercury. A cost-effective norepinephrine to help alleviate financial burden, a norepinephrine that cares for the environment. Norepin is an ideal norepinephrine solution based on clinical studies and guidelines. Norepinephrine is recommended as the first-line vasopressor for adults with COVID-19 and shock. Norepin passed the Institute of Pharmaceutical Sciences National Institute of Health in UP Manila with an assay test result of 106.7%. Norepin is cost-effective compared to the Innovator brand and can provide a savings of up to 23,000 pesos. Norepin 10 ml preparation can cut the number of ampules to be opened by 40% compared to the Innovator brand. Thus, it helps lessen the medical wastes. Moreover, Norepin 10 ml preparation has the following advantages. Be a part of our CSR advocacy and world vision. Your prescription doesn't just save lives, but transform the lives of these children in world vision. Every time you request Norepin at the pharmacy means sending a child to school and help fulfill their dreams.
All right, there you have it, ladies and gentlemen. It's time for Q&A. We encourage everyone to type in their questions in the Q&A box. I am pretty sure you have lots of questions for our brilliant speaker. To answer your questions, I would like to bring you back our speaker, Dr. Arun Bansal, together with our moderator, Dr. Mary Joy S. Torres. To the virtual stage doctors.
Hi, good afternoon, everyone. Congratulations, Dr. Arun, for the very comprehensive lecture. We have around 2,100 participants all over the country. And actually, I saw one coming from Malaysia. Hi, hello, good afternoon. We have several questions in the Q&A box right now. So I actually chose several questions. We have the first question came from one of pediatric endocrinologists in the Philippines, Dr. Lorna Abad. Her question is about hyperglycemia. How do you explain the hyperglycemia in a patient with TBI?
Yeah, thank you, Dr. Joy, for giving me an opportunity to speak. So it was good fun. So it's a really an important question. Hyperglycemia, like I said, is quite frequently seen in traumatic brain injury patients. Hyperglycemia is more common than hypoglycemia, which we see. And hyperglycemia is also associated as an independent risk factor for poor outcome. So there are multiple factors or reasons which can lead to hyperglycemia. One is the stress, is the most common reason because of the stress of trauma. Then inflammatory reactions which occur because of this trauma inside the body also lead to hyperglycemia. The other is if there is any injury to the pituitary hypothalamic axis, that can also lead to significant hyperglycemia. So multiple factors can play a role in that.
Yes, can I have a follow-up question for that, Dr. Arun? In terms of hypo and hyperglycemia, what would be your threshold of capillary blood glucose in treating patient with hypoglycemia or hyperglycemia? Do you have an acceptable value or a limit for that?
Again, it's a very valid and important question, but unfortunately, we don't have much data on it, that what are the exact upper and the lower limits. But what has been said in the guidelines or the literature say that, and what we follow is somewhere between 120 to 180 milligram per deciliter. So we try to keep somewhere between that.
Okay, thank you for the answer. Another question would be the use of mannitol and hypertonic saline. How do you often request for serum sodium when you are giving mannitol or hypertonic saline to the patient? And what is your target sodium?
So nowadays, since last few years, we have been using hypertonic saline. So we have stopped using mannitol as a first line or as a routine drug. Mannitol is restricted only if there is a impending herniation. Otherwise, we are not using it, and we have used it very, very rare, occasionally or rarely. Hypertonic saline in all raised ICP cases, we start upfront, and we monitor the serum sodium every 6 hourly in that cases. We try to target the serum sodium below 150, and we definitely don't allow to go it above 155. Again, the upper values of serum sodium are not known, but anything above 155 is dangerous. So we try to limit it below 150. And we also measure the serum osmolality, which is we see that it is below 360 in that case.
Okay, thank you for the answer. We have another question here. Do you recommend cranial CT scan in a patient with contusion on the scalp, even if the patient has no signs of increased intracranial pressure?
See, again, CT scans have been very frequently used for even mild or TBI or asymptomatic cases. So I would say that the type of injury does not matter. It is the severity of the injury which will decide your indication for CT scan. So if your child is asymptomatic and is well and is playing, there are no neurological deficit, And if you follow any of those rules, like I said, the pecan rule is which we follow in our unit. And if that satisfy that, we don't do the CT scan, we just observe the child for a few hours. And then if he is improving or is well and playful, so we discharge or send him home without any neuroimaging. But if the child is having any of these symptoms, like loss of consciousness, any bleeding, any fracture or to the skull or injury, persistent vomiting or headaches, even in a mild case, then we will go ahead and do it.
Okay. In regards to that question, there is also another question here. When is the conclusion considered a mild brain injury? And I think another question reliable to that would be, when do the symptoms of mild brain injury emerge? If you saw a patient in the ER, what are the things that you should check if the patient is having increased ICP?
Yes, again, both are very important questions. So concussion can lead to mild, moderate, or severe injuries. It can lead to any of these. Again, it is about the impact, the severity of the impact, and also about the part of the brain which gets affected because of the concussion. So a mild concussion can lead to maybe asymptomatic or even a mild injury can occur and the child may be normal. So it all depends on your clinical examination and the course, which will tell you whether your child falls in which category of severity. And then the next question is that in the mild cases, sorry, I missed that. Which was the second part of the question?
How would you check if the patient in the emergency room is already presenting signs of increased intracranial pressure?
Yes. So again, these are universal signs of raised ICP. That is, persistent headache is there in an adult or adolescent child can tell you whether significant headache is not there. Vomiting, any episode of loss of consciousness, child is having any posturing, episodes of seizures, decerebrate or decorticate posturing, brisk reflexes or upgoing planters, again are those examination finding which will tell you that this child is having some kind of, on the pupillary examination also. So these are the features which will tell you that child is developing features of raised ICP.
Okay, so that is actually a very important point, Dr. Bansal, because we actually don't have the luxury of CT scan in other places in the Philippines. Yes. So for our audience, so always check if there are signs of increased intracranial pressure that has been answered by Dr. Bansal. We have another question here, but thank you to Dr. Herbert Michael for answering. But do you have other answer for this? For severe TBI, upon arrival at the emergency room, is intubation needed immediately, or can we have bag mask or positive pressure ventilation first?
Yeah, again, a very relevant and important question, because not only in TBI, in any disease or in any acute illness, if a child presents to emergency, our first steps are always the ABCs. So bag and mask ventilation, if done properly, can take care of your airway and breathing. So need not worry about that. You can always, intubation should always be under controlled environment, and once you have taken stock of the situation, you have got a hold of the patient, you know what you are dealing with, you have arranged your drugs,
yes,
you have arranged your personals, only then go ahead with intubation. Emergency intubations are only when the child is, let's say, is arrested or that, but in that case also you can do the bag and mask ventilation. So initially for a few minutes to some time, bag and mask ventilation is good enough to provide adequate oxygenation and ventilation. So don't rush for intubation at emergency when the patient arrives.
Okay, very good answer. We have another question here. In a toddler who have a very high level of energy, who always hit or bang their head, or accidents that involve their head, are they prone to this traumatic brain injury?
Yes, that can happen because the concussion injury or these coup and contra coup injuries can again occur. Whiplash injuries can occur with that. So you can have all these. So all these are non-accidental traumas are also similar. If we shake the child like this, even that can also lead to significant injuries in the brain. So if they are banging the head to something, then they are prone or they are at risk of developing injury to the brain.
Okay, so we have another question on nutrition. Do you feed patients with TBI after 24 hours of stabilization? When do you usually start feeding the patient?
We try to start enteral nutrition as early as possible. So once the patient is stabilized, and we have taken care of the hemodynamics,
Yes.
we have controlled the bleeding.
Mhm.
Sometimes we start as early as between 6 to 12 hours also, but not fully, but we start a partial nutrition and gradually make it to the target nutrition by approximately 48 hours. So that is what our targets are. If the patient is going for surgery, then obviously it gets delayed. Once the patient come back from surgery and is then stable, then we start nutrition around 6 to 12 hours post surgery once he is settled and stable. But yes, our aim is to start early.
Okay, so in several studies, a patient who was fed early has a good outcome. So we have another question here. I think this is a nice question. For pediatric patients presenting at the ER with complaints of vomiting or headache, with a recent history of head trauma, at least 1 week, is it still attributable to the, is there associated TBI in that? There,
Yes,
the
again,
trauma.
yeah. See, any head injury patients, the symptoms can manifest within hours and can take up to days to present also sometimes.
Okay.
So if a child had a fall 1 week back and now is presenting with severe headache or vomiting,
Yes.
neuroimaging is a must at that stage.
Yes.
You have to rule out that whether any insult to the brain has occurred or not, and treat it as a potential case of traumatic brain injury and treat as per that protocol.
Yes, I think the history of traumatic brain injury in that case is very contributory to the management of the
Yes.
patient. Yes.
Yes.
Another question. It was stated that therapeutic hyperthermia may do harm to patients. What age group or specific characteristic must the patients have to warrant the use of therapeutic hypothermia? And Dr. Bansal, can you also elaborate the range of temperature that we need to target when we are using therapeutic hypothermia to our TBI patients?
Yes. Therapeutic hypothermia got fancy in the early 2000s and in 2010 when there were a lot of studies in all in traumatic. There were many studies in post-cardiac arrest state also. But then it went away because it was shown that it does not have any significant mortality benefit. In fact, in some of the studies, it showed that the hypothermia causes more harm than doing any good. So similarly in TBI, now currently what the evidence is that hypothermia should be done reserved only in cases of severe TBI. And that also when their child is going into refractory raised ICP and we are not able to control our ICP with all the means, like we have tried hyperosmolar therapy, we have tried even barbiturate coma, and other means have been done. Then you can try as a last resort. Only in these critically ill children, hypothermia has been used. In these cases also, it is the mild hypothermia which is important. Usually we target somewhere not below 35 degrees Celsius in that case, and we try to maintain in that. Having said that, what is important in this is that though we don't know whether hypothermia is beneficial and what is the lower limit, but hypothermia is, or the fever is more dangerous.
Yes.
So don't let your child go febrile. So at least maintain euthermia from start, and don't let the temperature go up. You can use antipyretics at that stage if fever is coming up. That is proven and it is dangerous.
Yes, because your hyperthermia will actually increase the metabolic demand of the patient. Okay, this is another question from Dr. Herbie Uy. Do you use citicoline in patient with traumatic brain injury?
See, I have not personally used that, but what I have read is that it is mainly been tried to see the cognitive outcome or the long-term neurological outcome post-traumatic children. But it has shown that it's not been of any proven benefit in whatever, and there are very limited data on it. So whatever data is there, it shows that it does not improve your long-term cognitive outcome with the usage of these drugs.
Okay. So I will be reading some of the questions. Actually, we have several questions here. What is the usual IVF regulations or rate you do to prevent or counter the intravascular volume loss because of hypertonic solutions? Do you usually practice adding, let's say, 10 to 15% of the maintenance when you are using hypertonic solutions?
Yeah. See, if we are using mannitol, which now we, like I said earlier, we have almost stopped using mannitol. It's a very potent diuretic. So if you are using mannitol in very sick, critical or very terminal cases like impending herniation, then we monitor closely the hemodynamics. We monitor the urine output, blood pressure, and other hemodynamic parameters. In case there is a trend towards fall in the blood pressure, we give a fluid bolus and try to build up the intravascular volume status. But if we are using the hypertonic saline as a hyperosmolar agent, it does not cause any intravascular volume changes. It does not cause diuresis. It does not lead to any volume changes. So they don't need any increased fluids. So that's the plus point of the beauty of hypertonic saline, that it's very much hemodynamic protective. So you don't need to give anything extra in that case.
Okay, that is a very good answer. So for that question, when you are using hypertonic saline in your practice, you don't need to add any fluid because there is no actually intravascular volume loss when you are using your hypertonic saline. So I have another question here. What is your initial vasopressor of choice in patient with distributive shock secondary to spinal injury? What do you
now we use epinephrine as a drug of choice in that cases as a first line drug. We have stopped using dopamine in these cases now and moved away to that. Yeah.
Okay. Are there any more questions? So I think let's entertain some few questions here. In the absence of an ICP monitor, aside from the clinical findings, can we rely on other measures like using your POCUS?
Yes, there has been now a lot of focus on non-invasive measurement of raised ICP. So in that, ultrasound is now coming up in a big way. I quoted a couple of studies on that in which they have used optic nerve sheath diameter as one, transcranial Doppler is another, and you can measure the optic nerve sheath diameter over means intermittently over a period of time and see the progression, and measure the optic sheath diameter. And if it is more than certain cutoff values, in our studies we have shown it is 4 millimeters. So anything above that is suggestive of raised ICP. Similarly, if you're using transcranial Doppler, you can measure the pulsatility index and the resistive index. Recently, there was one paper by Michael Bell and Carrie Lubrick. So they are from Boston Children's Hospital, US. So they have published the cutoff various cutoff criteria, age-wise on the pulsatility index and the resistive index, which will guide you that this is raised ICP or not. You can follow that. It's published in Journal of Intensive Care a couple of years back. So if we follow that, we can have a non-invasive measurements by using the bedside POCUS.
Okay, so I think Dr. Arun, this would be the last questions. Some questions were actually directed to pediatric neurologists. So does TBI may cause any developmental delays?
Shall I answer that?
Yes, you may.
Yeah, okay.
Yes.
I'm not a neurologist, yeah, but I can.
Yes.
Yeah. So TBI has especially even moderate TBI, but definitely severe TBI can lead to significant long-term neurological outcomes, which can include functional, cognitive, emotional. Any of these can be there, problems can be there, and they can have very significant impact on the child in the long run. So yes, Long-term neurological outcomes are known to be poor, especially in severe TBIs.
Wow, okay. So this is really a great discussion for everyone. We have several questions, but due to time limit, we will try to answer some questions. We will try to type our answers in the chat box. So thank you again, Dr. Bansal, for a very wonderful lecture and for enlightening us this afternoon. And thank you, Delex, for giving us the opportunity for joining us, the SPCCMP, in this afternoon's lecture. So thank you, everyone. And
Thank you. Thank you. Pleasure was all mine. I really enjoyed it.
Thank you, Dr. Bansal.
Thank you, doctors. Now, we would like to present this e-certificate to Dr. Arun Bansal in grateful recognition and appreciation as speaker during the PICU M.R.T. Season 2 third station with the topic Pediatric Traumatic Brain Injury 101, given this 20th of April 2022, signed by Dr. Adelia G. Cipriano, Program Director, and Mr. J. De Reuter C. Oroseo, Chairman and CEO of Delex Pharma. Thank you, Dr. Bansal. This next e-certificate is presented to Dr. Mary Joy S. Torres in grateful recognition and appreciation as moderator in PICU M.R.T. Season 2 third station on Pediatric Traumatic Brain Injury with the topic Pediatric Traumatic Brain Injury 101, given this 20th of April 2022, signed by the same signatories. Thank you, Dr. Torres. And to our wonderful participants, this e-certificate is for you for successfully completing the 2-hour webinar on PICU M.R.T. Season 2 third station, Pediatric Traumatic Brain Injury, with the topic Pediatric Traumatic Brain Injury 101, given this 20th of April 2022, signed of course by the same signatories. Together with this e-certificate, you will receive a self-directed CPD application form. And to formally close this afternoon session, let us welcome one of the hard-working district managers of Delex Pharma. Here is Mr. Alan Roy, Austria.
Thank you for attending our PICU M.R.T. third stop today. We hope that you have gained knowledge and understanding pediatric traumatic brain injury. We would like to express our heartfelt gratitude to one and all, from our excellent lecturer, Dr. Arun Bansal from India, up to our pediatric ICU faculty. Your dedication and effort in making this pediatric ICU forum successful are embedded in our hearts. We hope that the valuable information and best practices shared by our distinguished speaker will be a guiding light to your profession. Likewise, this added knowledge would pave the way to inspire you to think of new ways on how to be the best partners in providing quality healthcare to your patients and customers. Secondly, Delex Pharma International aims to bridge the gaps in critical care by providing quality and cost-effective medicines and medical devices to the greatest number of people. The hospital sales representatives and district sales managers visiting you in your respective pharmacies, critical care units, operating theaters, and emergency rooms will ensure that they can fulfill these vital roles during their engagements with you. We hope to continue and grow the partnership with you to provide the best quality healthcare to all. Maraming salamat po.
The ICU Forum invites you to its upcoming webinar on obstetric emergencies on May 11 at 3 to 5 p.m. We would also like to invite you to PICU Forum Sports Stop on June 22, Wednesday at 3 o'clock to 5 o'clock p.m. See you there. And to get the latest updates and webinar schedules, please like and follow us on these social media platforms. And that's the end of our session. We hope to see you again for another learning session. Please stand by for the post-evaluation QR code that will be flashed on your screen in a while. This has been your host, Joanna C., saying thank you. Stay safe and healthy, everyone. God bless us all.